very amenable to treatment by chemotherapy for various reasons, including the presence of a plasma peritoneal barrier. And unlike metastasis to other organs like the lung or the liver, the results of chemotherapy in peritoneal metastasis is not very great. And partly because we really don't know the answer to that. Most of the trials in advanced stage 4 colorectal metastasis that have looked at various chemotherapy agents, targeted therapy, immunotherapy, have included a very small proportion of patients with peritoneal metastasis. In this data, probably only 2% of patients who underwent all these targeted therapy randomized trials actually had peritoneal metastasis. So we are just extrapolating whatever we know from lung and liver metastasis to peritoneal metastasis. Unfortunately, peritoneal metastasis have a totally different biology. Like we mentioned, they are all CMS4 type of colorectal cancers, and unlike liver metastasis, the molecular profile of peritoneal metastasis more or less mimics what you find in the primary tumor. So the chemo resistance is inbuilt into peritoneal metastasis. But at the same time, mirroring the advancements that we saw, that we have seen in liver metastasis from colorectal cancer, we have seen a sharp jump in survival of patients, select group of patients with peritoneal metastasis from what was around 6 months, 2 to 3 decades ago, to now nearly 40 months. Select group of patients at least. And we already know that this is not because of the advancements in systemic therapy. So I think we as surgeons must congratulate ourselves for having come to where we are right now. So in this panel discussion, I think there are some questions that need to be discussed. I'll just be concentrating on these questions. Can peritoneal metastasis be prevented? How do you manage an incidental peritoneal metastasis? Is there a role for HIPEC in colorectal peritoneal metastasis? How do you choose a patient? And how do you integrate systemic therapy with CRs? I already told you systemic therapy by itself does not have a great role in peritoneal metastasis, but we cannot completely ignore systemic therapy also in patients with systemic disease. So I'll take you through 2 cases, time permitting. This patient is a 25-year-old male who had abdominal pain for 4 months. After wandering around, he finally got a colonoscopy done, which showed an obstructive growth at 40 centimeters. Biopsy was a poorly differentiated adenocarcinoma. CE was normal. CT showed an annular thickening in the descending colon. It was reported as CT4A and 0M0. These slides are courtesy of my colleague Dr. Rohin Mittal from CMC. This patient was planned for a left hemicolectomy. Intraoperatively, there was a large tumor in the descending colon. There were a few perilesional deposits in the peritoneum and few deposits on the colon near the primary tumor. And thorough laparoscopy was done. There was no other evidence of metastatic disease. Okay. So I have listed some possible management options for this situation. So this is what we call a incidentally detected peritoneal metastasis. We were not aware when we went in for surgery that this patient is likely to harbor peritoneal metastasis. This came as a surprise to the surgeon. This is not an uncommon happening even today. There was an estimate that nearly 40% of patients with synchronous peritoneal metastasis and colorectal cancers are actually diagnosed on tape. So what would you like to do? So the panelists, please have a look at the options. Would you just do a proximal diversion stoma and then send away the patient for palliative chemotherapy? Would you do just a left hemicolectomy and then send the patient to the medical oncologist? Or would you do a cytoreductive surgery? Or would you do a cytoreductive surgery or a hemicolectomy and combine it with HIPEC or CRS HIPEC in the same sitting or a separate sitting? Or would you just do nothing, back out and then come back another day for CRS HIPEC? Or would you do a proximal diversion stoma and send the patient for neoadjuvant chemotherapy? So anybody would want to, Dileep, would you want to take that question first?
Which was either 5 or 6? 5th or the 6th one?
The 5th or the 6th one.
See, we have a diagnosis of T4A lesion, so probably we would have taken a consent, we would have discussed with the patient, and if it is, and then the HIPEC would have been there, we would have talked about HIPEC. But otherwise, if it's on diagnostic lab, we found this, we might back out, talk with them, prepare for early HIPEC. And that would be my choices.
So in a patient with CT staging of T4A, would you always
we discuss.
Talk to the patient about potential metastasis?
We discuss.
Is that the practice on other surgeons too?
Since our experience in cytoreductive surgeries has improved over the period of time, and the non-availability of HIPEC machines always, it is difficult to do the HIPEC at the same sitting. But doing a CRS at the same sitting is not a difficult option, and that's what I prefer to do. A CRS, do the complete resection of the disease as end block with the involved peritoneum and the bowel. And anastomosis and stoma as per
so
what is...
you would do a CRS but you wouldn't do a HIPEC?
Yes.
Aswin, do you do the same or what would be your...
Ideally CRS and hypertemic therapy, I issue the consent, even though the relatives will understand, but legally I don't think, we don't prep every patient.
You cannot do it without the patient's consent.
Yeah, so we don't prep every patient. It's highly unusual to tell them that that there might be a T4 or there might be an M1. So I think option 6 would be my choice.
Pradeep?
You want a mic?
For obvious reasons, we'll have to discuss with the patient also. So we will back out on that day. In the same admission, we will plan and we will plan this.
Boben, would you be comfortable in sending the drug to the OT if you have not even discussed this with the patient and the surgeon suddenly calls up from this theater and says, look, we have a patient, I want to do that?
Suddenly calling from the OT, definitely it's not possible in the situation. But I would take a different approach. The patient is a 25-year-old, the family has not been mentioned. So being an young patient with an advanced colorectal cancer, I definitely feel like it should go and do the next generation sequencing and try to identify any molecular markers. The different approach can be provided.
That's right. So you're not going into the...
I agree.
Yes.
I would go with Dileep because the status is by the radiological investigation now. We have some idea about it and it's an obstructive disease. But by the CT scan it was not an absolute obstruction. There was some amount of colonic thing was there. So I would go like what Dileep says,
He gave two options.
No. I would go for that, the same sitting. In the sense we prepare everything. We prepare our medical oncologist also, and we have quite available. Patients are now available in plenty. So we go for that option 5. And we usually discuss with our patients and elaborate. And what we do is involve peritoneal. That's what we do.
All right. So if I say that I will do a hemicolectomy or CRS at that time, and then because the patient is not prepared for a HIPEC, I'll probably come back after 2 weeks or 1 month and then do the CRS, the HIPEC. Is that an acceptable alternative? That is number 4. You don't do HIPEC at that sitting, you just do a cytoreductive surgery. Since you're not prepared for HIPEC, don't do HIPEC, come back after 2 weeks, come back after 4 weeks, and then do HIPEC. After all, just HIPEC is just going to take 1 hour. Why not do that?
Pradeep actually says you can do CRS, you can get away with it, very small, you can. But the option of second one is probably we don't have data because of the prophylaxis and the protocol, which doesn't support the second look.
So other than the lack of convincing data on the advantage of HIPEC over only CRS, is there any other reason why you wouldn't want to come back and do a HIPEC after doing a major surgery? Pradeep?
So we don't want to violate the tissue planes in the first setting because those places will be the difficult situation when you go out for a CRS again. They have the disease hidden there, so it will be difficult to clear there. So better not to violate planes in the first place. Plan for a CRS HIPEC, better do it in the same setting.
So I think the point mentioned by Pradeep is something very important, that is one of the take-home messages that we should have from this panel discussion. Never do a staged HIPEC procedure after you've done a CRS, because there is something called the cell entrapment theory where the very act of performing the surgery, where you cut through blood vessels, you cut through lymphatics, especially in a T4 tumor when there is already free intraperitoneal cells, these are going to get lodged in the raw area that the surgery creates, and very soon they are going to be encapsulated by fibrin. And if you don't do HIPEC at that time and you come back after 2 weeks or 4 weeks, by that time they are all the free peritoneal cells are all within the fibrinous tissue, and your HIPEC is not going to penetrate them. You must remember that intraperitoneal chemotherapy, the penetrance is only 2 millimeters. So if you have a thicker fibrin coating around that, then your whatever HIPEC you are going to do later is of practically no use. So I think, yeah.
With this kind of minimal PCR, do we really have very convincing evidence?
HIPEC,
Going
yeah,
to
so-
add anything to
So that is what I was asking Dileep. It is one thing on cell entrapment theory. The other, if as I said, there is really no convincing evidence on the superiority of adding HIPEC to just CRS, which we discuss later. So if you believe in that philosophy, then you are prepared for a major surgery anyway. You can just finish off your cytoreductive surgery at that stage. Yes, Dr. Aswin.
Then it means that people who do not have facilities for HIPEC should not be doing colorectal surgery.
Okay, so
Is it the right question?
I will leave that difficult answer to the panelists. Dileep, what do you think?
Nothing like that. We can do a good cytoreductive surgery in the same setting. And that is, we are also justified in that.
Definitely no. See, you should be operating. This is just another one armamentarium which is evolving at this point of time. It is not the final answer, because Rama is going to discuss about that. As Anil was asking, is HIPEC going to be really benefit in this city, in this particular city? We don't have an answer, clear-cut answer for that. So it doesn't mean that you're not supposed to operate.
We need to operate. So I get a message that we should do a hemitelectomy and a cytoreductive surgery. And
If you are in this patient, you should not do only a This is M1 disease, he has peritoneal disease. So what you need to do is cytoreductive surgery.
and the extent of CRS.
Yeah. So I was about to ask that. I will come back to the panelists on that. So you need to do minimum cytoreductive surgery. Whether you believe in HIPEC or not is a different matter. If you believe in HIPEC, you don't have the facility to do HIPEC at that moment. Don't do a cytoreductive surgery at that time. Either come back or the next day after taking consent, or if you are not having the expertise for or the facilities for doing a HIPEC, you refer the patient to another center, but don't do a major surgery and then refer a patient for HIPEC. It is all right you don't do HIPEC at all, that is fine. But if you plan to do HIPEC, do it at the same center. That is a message that
See, most of the papers who addresses this HIPEC, they tell very important pointers. A complete cytoreductive surgery is the most important thing than that of the HIPEC. Because, as I mentioned, the whole thing is an evolution. So we are feeling that this might be having some benefit by all processes. So it should have some benefit. At this point of time, CRS is very important. Added to that is HIPEC. Correct,
and
Rama?
world over, in colorectal peritoneal metastasis, HIPEC is performed by colorectal surgeons. So colorectal surgeons are an integral part of
There is a role for chemotherapy also.
But it will also depend on the PCI score. If
for this patient, it is very minimal.
yeah,
Very
so
minimal.
if it is minimal, then you can add a HIPEC. Having the machine is not important. The important is that R0 should be achieved. Number 2 is the PCI score should match with the indications. Otherwise, doing a large peritonectomy, all these everything, and in spite of HIPEC, if the patient fails, and or there is some complication post-op, then you are in soup. So all have to be taken into consideration, and usually because our center have HIPEC machine, whenever such type of cases, as Dileep told, we always take a consent if required.
And drug.
No, we should not forget systemic chemotherapy also. Everybody is speaking only about HIPEC and cytoreduction. I agree that.
I have included plus systemic chemo.
Yeah, I understand that. But then the entire discussion is actually going that.
We'll never forget the medical oncologist.
Yeah, I understand.
They're very important in conferences also. We'll never forget it.
So you said you do a cytoreductive surgery. There was a question of what exactly constitutes cytoreduction. I said don't do only hemicolectomy. So what would you do? Of course you would do a hemicolectomy. What else would you do?
So this is on the left side. So I will assess the disease which our peritoneum is involved. And if you, most of the time it is the adjacent peritoneum.
In this patient, there are a few nodules in the left paraplegic gutter, a few peritoneal nodules just on the surface of the colon adjacent to the tip. That's all.
Then the steps will be that of the total parietal peritonectomy-like approach. And there will be en-bloc resection of the left colon with the involved peritoneum starting from the DJ flexure along the para-aortic region up to the pelvis, then from the midline.
In this patient?
Yes, wherever it is involved. That is involved
No, I'm
peritoneum.
telling you, there are few nodules only in the left paraplegic gutter. Rest of the peritoneum is completely free.
Then we can limit it to the from the midline to the. I still will be doing the same way from the paraduodenal space to the.
I think the issue here is, will you do a total parietal
No.
So that is very clear.
No total.
There is no need to do a total parietal peritonectomy in the peritoneal metastasis from colorectal cancer.
Only the involved peritoneum needs to be removed.
Ashwin, anything else you?
The first thing you should do is parietal fluid cytology, because always take it because it's a worse prognosis. Second, do a radical left hemicolectomy and involved feet. I would prefer to do a total omentectomy because those are the areas where sanctuary sites happen. And again, should we do an open or should we do a minimal invasive?
This patient was anyway planned for you have only done a laparoscopy. It's a very minimal peritoneal disease, and the additional thing that you need to do is just take a little bit more of the left paraplegic gutter peritoneum and do an omentectomy. So I guess the procedure could be completed
Can be done.
in the laparoscopic approach itself. Now, suppose this was a female patient. Would you do anything more?
In laparoscopy, it is difficult to assess the paraduodenal region. Mostly there will be disease in that area.
Why would it be difficult to assess paraduodenal region?
In all
You mean
cases,
the just next to the left of the ligament of
in
Reed's?
laparoscopy, it is not always possible to assess that area clearly. In all cases, it's not possible. If it is a very thin-limbed patient, by positioning we'll be able to see. But if it is a fatty patient,
The area that you are referring to, one of the hidden areas that Prof. talks about, is the area of peritoneum just immediately to the left of the ligament of Reed's area. That is one of the hidden areas. I'm sure that area can be very well visualized in laparoscopy regardless of the, because
Not all cases.
in a right hemicolectomy, when you are doing a bottoms-up approach, and you need to visualize that area to access the unseen. So
most of
I
the
beg to
cases
differ
will
with
be
you,
able
but I
to
think
see,
it
but
could be.
not in all cases, I think.
Okay.
My opinion.
You can use 3D laparoscopy. You will
Dileep, you were saying this is a T4 disease, so you are expecting peritoneal disease. How specific is CT staging of T4 disease? So
We might even sometimes, we might think there won't be any peritoneal. We might see much higher PCI patients with just T4 without any pre-op radiological disease. That also has happened.
I think we'll answer that once again when we talk about the next situation. But see,
Is
the thing
there
is,
any
it is
role
not.
for any PET CT or PAPI anything? Is there any role? You want to add on?
No, we will come to that. This patient is already on the treatment.
You started about radiology, so I went back to the radiology.
We will come back. Many of you talked about counseling the patient before surgery if it is a T4 disease. I find that practically very difficult thing to do. First, specificity that it is going to be T4 is not very high. Then you have to tell the patient there may be peritoneal disease, there may not be peritoneal disease. If there is peritoneal disease, I will see whether it is a low PCI or high PCI. If it is a high PCI, I will do this. If it is a low PCI, by the end of the thing, the patient, you do whatever you want. So, I don't think that, that is my experience. I'm sure your experience might have been different, but I'm just giving you a counterpoint on the practical difficulties of counseling all these things beforehand to patients. Yes,
Now suppose somebody has done a left hemicolectomy and referred a patient for that he had peritoneal mets. I have done a left hemicolectomy and I have now sent patient to you. Now will you send it to the medical oncologist or will you do a CRS?
So interesting question. I didn't want to include that paper. There was one paper that was emphasized. A small number, I think around 17, 18 patients who had only a colonic resection in the presence of incidentally detected peritoneal metastasis. Patients were taken up for HIPEC subsequently. The median interval between the first surgery and the HIPEC was almost, I think 45 to 60 days, somewhere in that range, because of the logistic problems. You know, patients come, you tell an estimate of something for a surgery. Now you're saying you're going to do a bigger surgery which is going to cost more. Not everybody would agree immediately, may not be able to cough up the funds necessary for that. So, and sometimes you may not be able to do HIPEC there, you might have to refer the patient to some other center. So because of all these logistical reasons, the interval between the two surgeries was in that paper at least 45 days. When they opened up again, nearly 50% of them had more peritoneal disease than what was documented upfront. And nearly 50% of them had to have a redo resection because there was tumor in the anastomotic site. These patients had a higher rate of stoma and a higher rate of anastomotic leaks. So this is another reason why you don't do HIPEC in a second stage. This is only one paper, but I think that gives a very valuable information as to what happens if you don't, if you want to separate the two processes. And in that time, the patient did not have any systemic problems.
For this, this is a very common situation. The first thing is you talk to the surgeon and say, are you sure you have done a complete central reduction? Is it CC0? If he's doubt.
No, I have not done. Yeah. I'm saying I have just done a hemicolectomy.
Yes.
I can't do a CRS.
Yeah.
I have sent it to you because I can't do a CRS.
Then I would prefer to talk to the patient and say I have to do a full CRS because it's ultimately it's not a CC0. Better to go into an open surgery, do a complete CRS and then do a HIPEC.
My other question was, will systemic therapy replace?
Not just replace. Would you agree to such a policy?
No, I don't
Because the
agree.
next surgery is going to take maybe at least 2 weeks. You won't operate on your patient.
Yeah, after 1 week, 2 weeks after.
And then has to be a major surgery, you have to recover from that. You're delaying systemic chemotherapy. Would you be happy with that?
So if you go into the literature, none of the studies have shown that by doing a HIPEC, that's a survival advantage. So what are we trying to achieve by doing a surgery that can add to the morbidity of the patient?
Leave alone HIPEC. What about cytoreduction? He's talking about a patient who's
I feel like we should give the patient chemotherapy, assess the biology of the disease, find out whether and come back in later, and if the patient does not have disease elsewhere, at that time, depending upon the situation, you can plan.
But we'll be giving the systemic chemotherapy when we already know there is a disease, right? So in the incomplete surgery, right? So we have a disease there, and we know systemic chemotherapy penetration is not good. So ultimately, the patient will say that there is a disease left behind. You're giving systemic chemotherapy, which doesn't work. Wouldn't it be better that we go in, do CRS with or without HIPEC anyway? I think. Have a CC0, make sure CC0.
So this will be a situation similar to perioperative chemotherapy versus. We'll come to that. So yeah.
In operator outside, we should check for the HPR also. If the patient has high nodal disease, in the left hemicolectomy specimen, I think we should not be aggressive locally. We should go for systemic therapy.
So this is a brief algorithm of how to approach a patient with incidentally detected peritoneal metastasis, depending upon various factors. Whether you counsel the patient, whether you have the expertise to do CRS, whether you believe in HIPEC, whether you can do HIPEC in that same setting. So there are different approaches, either immediate cytoreductive surgery or a delayed cytoreductive surgery or a late cytoreductive surgery. Probably have a peritoneal disease coexisting which was not picked up on the CT scan, and then you need to at least counsel the patient for cytoreductive surgery, or at least plan a laparoscopy. If you're not planning a laparoscopic resection, if you're planning an open surgery, at least plan a diagnostic laparoscopy before opening up the abdomen and then finding out that there is peritoneal disease. Right. Dileep has already given a lecture on this. Now Dileep, the dilemma here is you have a COLORECTAL study that said don't do prophylactic HIPEC. You have the Spanish T4 study that said do prophylactic HIPEC. What do you think is the right way forward?
The COLORECTAL is actually after 5 to 8 weeks. So it's the second look, the COLORECTAL.
Yeah, the HIPEC was done not at the
HIPEC was done the same
at least
sitting.
90% they had
In the same
staged HIPEC.
Yeah. So probably we have to design ways to do a proper HIPEC, probably in the same sitting and also the different drug. COLORECTAL was done with oxaliplatin, this was done with mitomycin, and that's why probably the HIPEC result of loco-regional recurrence rate was low. And for our country, I think probably more important is we think of decreasing the loco-regional recurrence. Because once it recurs, then you have to go for biologicals and a lot of things which is actually financially not viable in our country. So probably for our country, a prophylactic HIPEC for a T4A, T4B disease would be good and probably we should add a diagnostic laparoscopy in the algorithm for this high risk patients, just like gastric cancers.
Is that your practice? Would you counsel a patient for prophylactic HIPEC?
Current practice for T4 lesion, we don't do prophylactic thing.
Anybody else would consider prophylactic HIPEC? No, this T4 only showed an improvement in the loco-regional. The overall survival was not any different. So, do you still think that it is something important to the patient?
It is important in our country. It is important because if you can prevent just like the neoadjuvant trial, if you can again prevent the loco-regional recurrence, which means a lot. Actually, you don't have to give biological. Once it recurs, then systemic therapy, biologicals comes into play, and then you cannot be. And it's not salvageable. Most of the time, it's not salvageable.
So what Dileep is saying is, in a metacronus, if you identify a metacronus peritoneal metastasis, it is usually not amenable to cytoreductive surgery because by the time you identify it on a CT scan, the size is at least 1 centimeter in height, and going in, the previous surgery would have caused a lot of additions. The pattern of distribution of the peritoneal metastasis will also be different. So, the chances that you would be able to successfully perform a complete cytoreductive surgery in a metacronus setting is always likely to be low.
So, will that not depend on when the disease occurs? The time frame, the disease-free survival and all those things? That interval will not matter?
Generally, your disease-free survival of 1 year, at least in liver metastasis, within 1 year, the results are not very good.
But surgical intervention, whatever you're talking about. So if it is going to be a short time from the metacronus, then obviously the biology of the tumor is bad, and we'll start talking about those things. So if it is going to be longer period, then obviously we'll be again entering inside with an intention to cure the disease. So both the entities are entirely different.
Yeah, I understand. So you're talking about the biology.
Yeah.
I'm talking about the practical aspects of being able to identify disease at a low disease burden, low PCI, and then completely remove it.
So I also had something for you, Dileep. See, when you are talking about this prophylactic, so again your surgery is a part of it. That's not the main thing.
Yeah.
The whole thing will
100% is 100% cytoreductive surgery. That's all.
So again,
This is just an addendum.
it's because again this guy did not tell about the initial biology for the 26 years old who came with obstruction. Again, if the biology has been very bad, signaturing and other things, again you think too many times before putting your hand there. The only option you have is again the man who is sitting next to you needs to help us out.
So is there a standard of care now?
Very poor responsibility.
Yeah.
For T4 lesion, do you have enough evidence or is there a consensus of doing at the same sitting T4 business or right side prophylactic at the same sitting we do T4? Does anybody follow in the world or is there a consensus that the PSOGI guidelines since you are a part
Obviously,
of
the
it?
Spanish group that did this trial, I assume they will be following it because if they don't follow, then who else will follow?
Correct.
But I don't think it has yet come into the
So at
guidelines.
this point of time, T4 lesion, we just do.
There is no recommendation in the guidelines to perform. Probably that will change in the near future because this study just came out last year. So
Correct.
probably once the guidelines get updated, it might reflect that in a select group of patients with T4, there might be a role for HIPEC because that's how all the guidelines evolve. So as of now, it is not there in the guidelines. I think this is something that needs to be discussed with the patient. The patient needs to be given the information that there is some evidence that the chances that he will recur the peritoneum is less if I do a HIPEC now. But that is not probably going to influence how long you are going to live. If the patient is comfortable with that, if you are also comfortable in doing prophylactic HIPEC, I think you can quote this study and say there is evidence.
There are many centers which do this as a routine clinical practice. The Basic Stroke Group does it. They recommend actually. There are many centers which do it. But many centers do it as a clinical practice.
So now,
Rama, any role of salvage cytology? Cytology of the fluid.
yeah, so Ashwin was touching on that point.
Immunity for lesion.
Yeah.
If you have lavage cytology positive,
Yes.
then I think
Yes.
you are justified.
Correct. I agree.
But none of these trials included patients with cytology positive. In gastric cancer, the French trial, one of the indications is a cytology positive for doing prophylactic HIPEC, but not in colorectal, at least not far. But like Ashwin mentioned, the prognostic impact of a positive cytology, even in the presence of obvious peritoneal metastasis, it brings down the survival another notch. So it is good practice to do peritoneal level cytology, at least to know what is the prognosis of this patient.
I think the watershed will be mitomycin trials. Basically, use of mitomycin has started after 2020, right, in clinical trials. And that will change that is why I think, as Ayyappan said, it is a evolving thing. Because oxalipatin was the wrong drug. That is why we were not getting results with it.
True.
So this is the next patient, 61-year-old female, diagnosed with altered bowel habits and came with altered bowel habits. Colonoscopy showed a growth at 18 centimeters. Biopsy moderately differentiated adenocarcinoma, comes with a high CEA. CT scan, some thickening in the sigmoid. There was the tumor was infiltrating the adjacent ovary, and ovaries were enlarged, basically bilateral Fruchtenberg tumors. And the CT also identified nodules in the greater omentum and other areas. So M1C radiologically, T4A, and radiological PCI is 14. So any of you would prefer an MRI over a CT scan?
We do
Once
MRI.
you know that there is peritoneal disease, is there any advantage in adding an MRI?
As practice, we do contrast MRI peritoneum with predictive PCI.
No, here the radiologist on the CT is already said radiological PCI is 14.
But MRI actually picks up more, gives us more clearer idea.
How is that going to change your opinion?
No, it doesn't change, but just to document as a part of it.
Anybody else would prefer?
Yeah, I agree with for mesentery and small bubble MRI is much better. But again, since PCI is 14 for this patient, I would probably prefer to give my treatment won't change because the ultimate end of decision is, do you have to do any CT or do we have to go for upfront surgery?
So this patient underwent diagnostic laparoscopy. The intent was not very clear. This was a diagnostic laparoscopy, okay, not the intent to go ahead with resection. This was the findings. The distribution of the peritoneal nodules is mentioned. The final PCA score is 12. Do you think this patient can be cured?
We will treat with a curative intent. The sequencing of treatment will be different, but we will treat with a curative intent.
Anybody?
And the biopsy?
Moderately differentiated adenocarcinoma.
I don't think the patient can be treated with the curative intent. It should be the palliative intent. Surgery should be indicated only if the patient is symptomatic, if the patient has got obstructive symptoms.
Why do you say?
Patient has got this large amount of disease.
PCA is 12.
But the patient has got Fruchtenberg disease, mesocolic nodes, large amount of nodes, M3 disease. What are we trying to achieve from that thing? How can we, how can you say that?
The diseases, if you look at the distribution, the disease is predominantly on the left side.
MDT.
And the
MDT.
Yeah. It depends upon how you want to take it up. But I feel like
No, okay.
for the quantity of the disease, which we feel is that.
Assume this is an MDT. The discussion is whether, so you feel that this patient is not for a curative treatment. What would you define as cure in a patient with peritoneal metastasis?
Cure means like you have to cure the patient of all the diseases.
No,
Do
do you have any objective definition for?
There is no objective definition. Cure means like you have to cure the patient of local disease and to prevent systemic disease from happening. If you are only treating the local disease and if the disease is going to recur systemically.
Suppose this patient didn't have peritoneal disease. Assume this patient doesn't have peritoneal disease. CT4 and 2 and 0. After the surgery, patient asks you, doctor, am I going to get cured? Will this surgery cure? What will be your response?
What would the stage at that time? The surgical stage?
PT4A and 1.
N1.
Or assume it's N2.
N2. I feel like okay, the chances of curing the disease is very less. We have to continue with the systemic treatment and see whether the disease, how the disease is evolving.
So, is there any accepted definition for cure? That's what I'm asking. Anybody knows any accepted definition? Because we keep on saying cure. What is cure in a patient with cancer?
Rama, you are touching the basics now. Don't do this.
Unless we know this, we cannot answer the questions that the patient asks, which every single patient will ask.
A good quality and a quantity of life. That's at least whatever you talk about, in all the statistics, whatever you talk about is a 3-year disease phase or a 5-year disease phase.
Yeah, okay.
That's what
I'm
these
asking.
two numbers you are talking about.
Yeah.
So
Is there any number that will indicate cure?
Generally, all the statistics when you talk about either 3 years disease phase survival or the 5-year disease phase survival. That is what we talk about. All papers, whatever you say.
3 or 5.
Sir,
The man here has hit the nail on the head. So, there are some papers in colorectal liver metastasis and in peritoneal metastasis where they define cure as 5-year disease-free survival. Patient is alive and free of disease 5 years from the time the treatment was started. That is what many people consider as cure. So, do you think this patient can live till 5 years without recurrence?
Don't think so. Because of the amount of the disease which the patient has, the chances of her living for 5 years is very less.
sir, if we are able to do a curative intent treatment for this patient, the chance of living for 5 years is actually there. Because in this case, this limited peritoneal disease, for a surgeon, as a surgeon's point of view, we can actually achieve a R0 resection in this patient and hope for a curative intent treatment. Obviously, there can be systemic recurrences, but our attempt is always go for a curative intent treatment. But that could be given for this patient because of the limited peritoneal disease.
Median survival with systemic chemotherapy in a peritoneal disease is 12 to 20 months.
16 to 19 months.
And with cytoretic surgery, and this the median survival in the Proteus trial was 40 months. So, talking about cure in this.
Okay, Boben, I'm giving you another situation. This patient comes back to the MDT. You say you do an MSI. I do an MSI. It is MSI high. How do you think this patient can be cured?
Even then, the chances of curing the patient will be less. So, see, just because the patient is having high MSI and the option of immunotherapy is there, that does not mean that we are going to cure the patient.
Correct.
Not going to cure. We can keep the disease under control. How to control the disease, how long we can keep the disease under control, that's a totally debatable issue. That depends upon the tumor biology, how the patient is going to respond, all these things. So once you do the surgery and then the recurrence comes, the patient is following it with the medical oncologist. First line, where we give chemotherapy and then the disease recurs. Patient is not going to come back to the surgeon. The patient is going to
Once the disease recurrence happens, then it comes out of the definition of cure. So
that is the issue. See, once the patient is, once the disease
so you
has
don't
recurred,
think the patient will live for 5 years without a recurrence?
the chances of
I think
patient is very high.
majority of surgeons would feel otherwise. At least they will have a hope that this patient, there is a possibility at least that this patient, because, okay, so let me ask you, in what level of PCI do you go ahead with surgery?
There is an objective way of analyzing. For some people, this is a high burden. For some people, this is a low burden. So So when we go to the PCI, there is a very objective way of seeing what are the burden. So PCI 12, according to the data, because 15 is a cutoff. If it is less than 15, this is supposed to be low burden according to again evidence. So for this patient, definitely I would say first curative. You cannot push the patient to palliative treatment. Now the only issue for me is,
would everybody agree that less than 15 PCI, you would still consider this patient for cytotoxic surgery and a potential cure?
So more than the numbers, it's the area involved, colorectal. Because unlike in other ovarian malignancy where we take for a planned cytoreduction, but here it's an unplanned cytoreduction that we are doing.
But you have already done a diagnostic laparoscopy. I am not telling you this patient is going to have surgery. You plan your cytoreduction.
Okay. In that case also there is no.
Now suppose I say this PCA of 12, the score contribution 3 is from the terminal ileum mesentery, 3 is from the mid ileum mesentery, 3 is from the proximal jejunal mesentery, and only 3 is related to the T. Do you think that patient and this patient would have a same PCI score, different distribution of peritoneal metastasis? Will there be a difference?
Yes, there will be difference, sir. But this is a left-sided colon with a right-sided peritoneal involved.
Not right-sided. And the ileal mesentery, I'm saying. Ileal mesentery.
If it is cytoreducible, then it does not make any difference. If it is cytoreducible.
It should not make a difference.
Yes.
But 3,339 score in the mesentery. Do you think it is worthwhile attempting a cytoreduction?
Small PCI is more than 4, then I think the chances of cure is very less.
So the point that we are trying to
The
make
size
here
of the
is-
deposits and whether it is invasive implants, it depends on that. Even if it is a surface implant in the small one, still we can cytoreduce.
It's not just that number that you see there. It's also where that number is distributed also makes a big difference in. Yes.
I think it's also about the age of the patient, the general condition. I mean, if this was a 40-year-old female with kids, you would be probably more. And second, one question to the medical oncologist: if the surgeon says I'm going to do a CRS, I'm going to give you an R0, and it is MSI high, would you be more optimistic?
Yeah, in that situation, I am more optimistic. Okay, you do a complete reduction and then we will see. Then we can discuss with the patient.
That is exactly what everybody is saying, that we are going to give you a patient with no residual disease. And instead is MSI high.
So that is the question that I want to discuss. How will you select a patient for cytoreductive surgery and HIPEC? And then we will discuss the other questions. So how will you select a patient for Pradeep?
From the disease point of view, the disease burden should be amenable for a CC0. And second thing, the patient should be medically fit and willing for the procedure. And I think these two are very important things. And other things are local logistics. These two are mandate.
Fair enough. So I think that, okay, so 3 important things that you need to consider: the disease, the patient, and the surgeon. Because these are the things that are going to influence the treatment. So, you said about signet ring cell. Does that mean that in a signet ring cell you will not offer cytoreductive surgery and HIPEC? Or will your threshold for PCA come down? What would be your threshold?
Maybe less than 7. Low PCA.
Anybody else has got a different threshold for PCA in a signet ring cell? So, I mean, it is subjective, but definitely you would want a lower PCI if you want to consider this in a patient with a signet ring cell carcinoma. I think we have already had the discussion about this is also. Of course, like you said, whether the patient is fit enough to undergo surgery, and like what Dr. Pradeep said, whether you are able to do a complete cytoreduction, which will again depend on the PCA score as well as the distribution of the peritoneal disease and your ability to do the surgery. Now, if this patient on the relapse, we found 2 small liver nodules, we take a biopsy from that, one in the edge of segment 3 and one in the segment 4B, around 1 centimeter in size, either of them, biopsy is positive. would you still consider this patient for cytotoxicity?
Still in a cytoreductive with a curative intent.
So, till what extent can you consider?
When you don't have to do a major hepatectomy, when we have 2 or 3 nodules, up to 3 nodules without a major hepatectomy, just doing a non-anatomical dissections in easily amenable areas, we would still do it.
Would everybody agree with that? Would you still consider CRS effect with limited liver metastasis?
Rama, upfront surgery you're asking?
Yeah, that's what the
Regardless, I mean, would that make a difference?
Upfront, because it's already a systemic disease.
Okay, in this situation, probably you push more towards neoadjuvant. But
Yes.
after giving neoadjuvant,
Yeah, obviously.
You would still
We are still concerned.
we would also consider neoadjuvant. We'll talk to the medical oncologist, do whatever is possible. Because again, I might use the same irritating word, the biology of the tumor. Because liver is going to get involved. That was a surface thing, whatever you were talking about. Now you're talking about the systemic organ involvement. So if liver is involved, we'd like to know the biology, give them a gap of about 2 to 3 months. We know what is happening to the rest of the liver and other solid organs. Then we go ahead and do whatever we want. At that point of time, any cytoreductive surgery is okay.
fair enough.
I have so this patient has a Krukenberg also.
Correct.
Right. So they
That is a surface again. Krukenberg is purely surface. It's not a parenchymal disease.
Now, allow me the privilege of asking that question. I know what you're going to ask. So, this is the SOGI consensus for what defines resectability in peritoneal metastasis from colorectal cancer. So let's come to Ashwin's. Ashwin's question is: this patient with the Krukenberg tumor, would you want to give neoadjuvant chemotherapy or would you want to operate? Is that right, Ashwin? Is that what you were wanting to ask?
Krukenberg, usually they say the NA is there, better to remove the Krukenberg because there's no, the systemic therapy penetration is less. So that's the reason I wanted to ask.
What would you do in the presence of Krukenberg?
Neoadjuvant therapy
So this is around 5 to 6 centimeter size. Easily removable, but would you want to remove it?
We might give neoadjuvant, but we know for sure that it is not going to respond. They might increase. If it's symptomatic, we might.
No, is it 100% you know that this is not going to respond?
Mostly it doesn't respond. Krukenberg.
Yeah.
What do you think that is not going to respond?
I don't try it.
It is. Krukenberg also do respond. We cannot say upfront predict that it is not going to respond. So when you are giving a neoadjuvant therapy, you should not go with the intent that it is not going to respond. You should be going with the intent that it is going to respond, it is going to downstage, and then you are taking up the patient for surgery. Right?
So let me put an intervening question. Do you reassess when you start your chemotherapy? When will you reassess the patient when this is the kind of biology that you are faced with?
After 3 to 4 cycles, that's what usually the surgeon.
So that is, I think, exactly what we should do, because otherwise we finish the entire cycles and the tumor has progressed.
But I agree with Dileep. I think most people who practice peritoneal oncology will agree with Dileep, and this is a practice in basic stroke as well. In a patient with a Krukenberg tumor, otherwise amenable for complete cytoreductive surgery, they prefer to do upfront surgery rather than send the patient for chemotherapy. And I have also seen people know patients with Krukenberg tumor, you send for neoadjuvant chemotherapy, patient comes back after 3 cycles, the size of the ovarian mass is doubled. And then doing surgery at that point of time, even though it is possible, it is going to make your life a little bit more difficult. So, and if answering your question, what we follow is, if we do send this patient without removing the ovaries for neoadjuvant chemotherapy, we just wait for 2 cycles and then do a CT scan. At least to make sure that it is not progressive. If it is responding, complete another 1 or 2 more cycles of chemotherapy and then on. Otherwise, so Ashwin, what would you do? Would you operate first in a patient with Krukenberg tumor or would you prefer neoadjuvant chemo?
I would prefer surgery. With PCI 12 and the cytoreductive is good, I would operate.
Now, you were talking about MSI. What about the other molecular markers? Would that, we know liver metastasis, BRAF mutant patient would be quite hesitant to offer liver metastasis because not that we didn't, but we know that the outcomes are not going to be good. Do you have any such data regarding the molecular profile of the tumor to decide whether this patient will benefit from CRS HIPEC?
studies are showing that okay, the trend is also moving that way. We have to do the genomic testing upfront, identify the biology of the disease, the molecular biology of the disease, and find out like who is going to benefit out of from what kind of a treatment, and try to offer a specific treatment.
So, this patient, he only had a laparoscopy. You already have a colonoscopic biopsy. The surgery is over, patient is referred to you. Would you tell the surgeon, I want a biopsy from that peritoneal nodule to send for NGS?
Need not be always. Need not. If it is easily accessible, if we had already, if we have a tissue, that tissue is fine enough. Otherwise, nowadays, if we are not able to get, we can do the liquid biopsy also. The technology is improving only. Then we don't insist. If you are able to have a biopsy, it's well fine and good. If you have a tissue, we will do that.
No, the question is, do you want to do the molecular profile on the biopsy from the primary or from the biopsy in the peritoneal?
That depends
Does
upon
that make a difference?
That depends upon whether it is in a synchronous setting or a metachronous
In the
setting.
synchronous patient.
Synchronous setting, I feel like one set tissue will be good enough.
So you don't necessarily need to do it from the peritoneal. Okay. So there is a lot of emerging data on the outcomes after cytoreductive surgery in HIPEC based on the molecular profile. KRAS mutation really doesn't make that much of a difference. But mutated BRAF with stable microsatellite outcomes are pretty poor when compared to MSI type. So you might want to consider that in the back of your head if at all you are sending this patient for molecular profile. So coming back to the basic question, do you think HIPEC is needed in the treatment protocol for peritoneal metastasis in colorectal cancer? Let us hear from the medical oncologist.
The data shows that it's not required, right?
Okay, now from the surgical oncologist, he is very clear.
Proteage has a lot of controversy, there is a lot of critics of Proteage, but we feel still that HIPEC is, it doesn't actually add much to the morbidity of the, apart from the cytoreduction. So HIPEC would be necessary, and it's only we have to figure out better ways to do HIPEC, to give better medications and better, probably in the Proteage it was oxaliplatin for 30 minutes. So probably figure out better ways to deliver HIPEC with mitomycin, probably increase the exposure. And
So
doesn't add much to the morbidity.
So if you are not familiar with this trial, this was a randomized trial that looked at only cytoreductive surgery or cytoreductive surgery with HIPEC. The final result was that whether you added HIPEC or not, the survival was around 40 months. But the take-home message from this was survival is above 40 months, even with only cytoreductive surgery. So I think Boben will have to agree that surgeons can also, improve the survival and probably cure patients with peritoneal metastasis. Of course, with your help.
The last statement is correct. We need the systemic treatment also. With our help. We will work collectively for that.
So what is your practice? HIPEC, no HIPEC?
Yeah, HIPEC, yes, because first thing, like sir said, we use the wrong drug till now.
So what will you use?
Mitomycin now. So oxaliplatin cannot, we are known it doesn't work. Mitomycin. Second thing is, this trial was, they use PCA up till 25. The PCA up till 15 is the best, because the sub-analysis here that PCA 15 is when the maximum benefit happened. Third, I think for everybody, the morbidity, like Dr.Dileep said, morbidity from CRS, HIPEC doesn't have that much of morbidity.
I think one thing is very clear, morbidity of CRS HIPEC is
much more
as high or as low as morbidity from ripples, morbidity from esophagectomy, morbidity from liver metastasis. So I think we are very clear that we can do a safe job. As surgeons, we can do a safe job. So I think that point is clear.
Rama, this Prodige 7 trial answers one of our friends' question, whether the colorectal surgeon should operate on colon cancer or something. So he was saying we don't do HIPEC, so should we operate? The proper CRS, this trial is for you, sir. You are asking whether colorectal surgeons can operate. They should operate, sir.
Of course, what I'm saying was with HIPEC, because to say that it is harmless is okay, but it's a financial burden.
It is.
We should not include that. There's no doubt about cytoreductive surgery. The HIPEC, it actually costs.
So HIPEC, no HIPEC.
Cytoreductive surgery, yes sir. HIPEC, still more evidence comes.
Yes or no?
No.
You won't.
Side reduction is.
So you don't do HIPEC at all? I mean, for colorectal peritoneal metastasis.
No, at present no.
Yes, for HIPEC.
And
PCI permits.
Drug?
Vital 60 months.
So,
Can I ask a question? I just have a concern with HIPEC because when, like the old trials on Zygris, like you say, one organ failure, it seems to work fantastically, but there's two organ failure, it doesn't work. No organ failure, it doesn't work. Activated protein C was the mantra, for example. So when you have subgroup analysis which show benefit, as an old dog, and you see the history of research, the observation that I'm tempted to make is that there is always that the floor is a little slippery and we should be careful, we should walk carefully. Therefore, a resounding yes for HIPEC, I would sort of ask again, I would ask my colleague if we work together, are you thinking the right thoughts? I'm just a little concerned. I would like your response to that.
So, in spite of the negative evidence, why would you still want to go for it?
I'm not supporting.
No, not you. You anyway said you don't want to do that.
So I agree right now, yes, but being an optimist, it's evolving because the only thing I think we got wrong was the drug. And giving 40 months, like I said, I want to ask medical oncologist, 40 months for a PCI high, before it used to be only palliative. Like we used to give only palliative treatment, but we found that even with PCI 25, who cytoreductive surgery gave 40 months survival. HIPEC, I feel with mitomycin, with another 5 years we'll get. We are already doing trials, mitomycin is safe. I feel that we should not disregard HIPEC because it worked in ovarian, it worked in mesothelioma. I have right now no benefit to say, I mean...
That's what I'm going to tell.
Why not?
I'm going to answer that question.
So,
Yes.
your concern is very valid.
No, I have further concerns.
The answer
I have further concerns that when a professional, my sins are going to be cleansed, that's fine for me.
So would you
But when
rather-
I'm applying it to a patient, I need more hard data.
So, would you rather that this trial never happened?
No, not at all. I'm very keen that we have another arrow in our armamentarium. But
Colorectal cancer only in a trial setting and institute setting. That's but HIPEC needs to be done. Then only we can bring the more data and later on we can improve the survival. What I said is I am not doing HIPEC means in the setting I work. It's not an institute where we conduct trials. We don't do experiments, but we have to do HIPEC in situations where centers like MBR, where they are doing large volume of patients with cytoreductive surgery HIPEC. Yes.
Chemotherapy works. That has been shown in hepatic artery infusion chemotherapy, that has been shown in isolated limb infusion or perfusion. In so many areas, we know that when you deliver chemotherapy to a confined space, the action of the chemotherapy is going to be more than when it is delivered systemically. So the theory is sound. We have not been able to establish it in a randomized trial as of now. So I think this discussion will stop there. We hope that we will get more randomized evidence, probably with mitomycin C. But for now, these are the reasons why the Prodigy 7 trial did not show a positive result. Do we have time to go further or shall I stop? Okay, unless you tell me, I will continue. So again, I think another important thing that we needed to discuss was, any of you are feeling bored that should stop, and please raise your hand.
Again, one more exercise you don't tell.
So the discussion was on whether to give chemotherapy or before surgery or after surgery. Evidence is emerging. I think this year ASCO, another month from now, the final results of this Cairo 6 trial will be out, where they looked at patients with peritoneal metastasis, colorectal cancer, operated upfront, followed by adjuvant chemotherapy, or given perioperative chemotherapy and then operate. Till such time the evidence comes, what would you want? Straight surgery or perioperative?
I feel like perioperative.
Any
to understand the biology of the disease and then take the call.
Any
Perioperative, even I will prepare because there is response to the ascites when you give, and it makes actually surgery easier. But don't wait for long, but we take it at second or third cycle.
Anybody has a different view? So I think many people would still do perioperative chemotherapy, but are there situations where, okay, this is the last slide. So there is an Indian consensus by the two peritoneal surface malignancy societies in India. Those of you interested can read up. This roughly mirrors the SOGI international consensus. So as of now, I think perioperative chemotherapy is routinely followed, but are there any situations where you would still want to go and operate first? Or any patient who walks in with peritoneal metastasis, would you send the patient for perioperative? I think both of you did mention that if there were Kuchenberg's tumor, you would operate first. Any other similar situation you would want to operate first? Okay, fine, impending obstruction.
It's a limited disease involving critical areas, probably we should not miss the window of opportunity. In such cases, probably we should go out for CRS first and then the systemic therapy. But depends on the PC again. If PC is high and critical areas are likely, probably then we will test the biology giving the HPB. If there is a chance that it might progress and make it unresectable in a limited PC, it's better to go for unresectable.
Mucinous adenocarcinomas, probably with the low PCI.
Why do you want to operate for? Again, response to
chemo is.
And also the first case that we discussed, when you incidentally found a peritoneal metastasis, you were scratching your head whether to close or whether to do a CRS. I think many of us would still complete a CRS, at least a CRS in that situation. So I think that's it. Thank you all.